Our next presenter is Danny Tsai. Now, Danny is the Acting Director of Clinical Research at Alice Springs Hospital and a Senior Research Fellow at Flinders Health and Medical Research Institute. His research focuses on antibiotic dosing optimisation, particularly in renal impairment and in First Nations patients with critical illness, and on tackling antimicrobial resistance in remote Australia. Danny will be walking us through the changes to aminoglycoside dosing for surgical prophylaxis and the data that underpins these changes. Please join me in welcoming Danny to the stage.
Hi, I'd like to first show my appreciation and my gratitude to Therapeutic Guidelines for inviting me to the panel, as well as to present some of the stuff that we have been discussing during the review. It was a very, very nice experience. It was a very safe environment, and we produced a lot of very interesting discussions. And today we're going to talk a little bit about gentamicin, and we want to talk about the changes that we are making in this particular section. We'll go through the reasons why and talk a little bit about the evidence that underpins these changes. So, of course, being a pharmacist, it's only customary for me to start with this graph. If you don't know this graph, you really need to spend more time with your pharmacist colleagues, okay? So this is a pharmacokinetic, pharmacodynamic. It talks about the bacteria killing properties of antibiotics. Basically, you can categorize them into three different categories. And there's the time concentration. There's a concentration-dependent antibiotics. There are the concentration-dependent with time dependence. This is more commonly known as the AUC-dependent killing antibiotics. And you also have the time-dependent antibiotics. Right? So for gentamicin or for aminoglycoside, it actually fits under these two different categories. So it's a concentration-dependent as well as concentration-dependent and time dependence. So it's concentration-dependent because that you have to reach a very, very good peak. Because the higher peak that you achieve, the longer the post-antibiotic effect. So because gentamicin has a half-life of about 2 to 3 hours, which means that by the time you get to about 10, 12, 15 hours into the dose, there's likely to be no detectable levels in your blood. But the reason why we can still use it as a 24-hour dosing regimen, it's mainly because of the post-antibiotic effects. So when we talk about antibiotic effects, post-antibiotic effects, it really is defined by bacteria killing during an absence of gentamicin in the blood concentration. All right? And that is only possible because when you reach a really high peak, then it actually pushes the antibiotic into the bacterial cell wall. So even when the serum concentration has dropped, the killing mechanism is still happening. However, there are a few issues with that. The first, and part of it, is that people generally don't know that gentamicin doesn't have very good post-antibiotic effect against gram-positive gram-positive bacteria. So that's why, like in endocarditis, you have to give it 2 or 3 times daily. All right. So as a summary of this slide, the main thing to get out of it is the post-antibiotic effect. It actually depends on adequate gentamicin infiltration or aminoglycoside infiltration into the bacterial cell wall, into the bacteria. Otherwise, it's not going to work. Sorry. Okay. However, so that was all well true in the scenario of treatment of a gram-negative infection. However, in a surgical prophylaxis setting, we are dealing with a slightly different issue because during surgery, your skin is not intact. So there's this risk of external pathogens infiltrating into the surgical site. So that's why you need the prophylaxis. However, these externally introduced bacteria, they have not been exposed to gentamicin concentrations in the blood. So that's why post-antibiotic effect doesn't actually apply in this particular setting. So that's all theoretical. So when we go back to this graph, concentration time graph, you can see that like in this particular case, we give a really, really good dose, we give it really short. It's sharp here, so it probably means that it's just a slow push. This is really what you want, or a very, very short infusion, so that you can reach a good peak. If you drag on the infusion for too long, then it's going to flatten out that peak. And the lower the concentration that you achieved initially, then it's going to reduce your post-antibiotic effect. So in this case, it's nice and sharp. And then it comes down. Sorry, I keep on pressing the wrong button. And then it comes down really quickly because half-life is about 2 to 3 hours. And then very quickly, you'll get to this point where the concentration falls below the target MIC. So this is for gram-negative infection. So the clinical breakpoint is 2 for E. coli and for most of the other gram-negative that you want to target in this particular setting. So which means that the post-antibiotic effect will last for generally about 4 hours plus minus. However, in the setting of a surgical prophylaxis, you cannot count on that. So you have to anticipate that prophylaxis action will stop around here. Okay, so this is all theoretical. This is all theoretical. So what are the evidence that actually backs this up? So there's this old paper that actually looked into it. They actually compared 2 different regimens in surgical prophylaxis in colorectal surgery. So they compared a 4.5 milligram stat gentamicin dose comparing with 1.5 milligram per kilo 3 times weekly during both starting at pre-op, and they look at chances of post-surgery infection, and then they actually find that in the lower dose group, they actually achieve higher rates of infection. So they thought that was quite interesting, but then it doesn't really answer a lot of questions for us pharmacists. So of course, we really want to get down to it. We really want to know the relationship between the relationship of the surgical post-surgical infection and the drug concentration. So this author, being a pharmacist, they actually did some pharmacodynamic analysis after the initial randomized control study. So they wanted to look at exactly that. They want to categorize the relationship between the concentrations and the incidence of the infection. And then what they found is that the first point is the most important point. Gentamicin concentrations at the time of surgical closure was the strongest independent risk factor for infections with a p-value of 0.02. Right, so this is significant, and that's along the side of diabetes, presence of stoma, and also old age. So just by noticing this, it actually tells us that we can no longer see gentamicin as an AUC or Cmax-dependent antibiotic. We really have to see it as a time-dependent antibiotic. We have to maintain the concentration above the MIC. So in the study also found that gentamicin concentration of less than 0.5 milligram per liter is associated with an infection rate of 80%. So that's pretty high. Though the numbers are not huge. And then they actually found a critical closure concentration of 1.6 milligram per liter for effective surgical prophylaxis. Right, so the translation of all of that is risk of surgical site infection is significantly associated with the gentamicin concentration at the surgical site at the time of closure. So then, 2 decades later, this other group of researchers, they come and they say, well, knowing that information, then we need to know exactly how much antibiotics we should give to patients that require gentamicin in these settings. So they did a population pharmacokinetic study. So essentially, after all the mathematical modeling and also simulations, this is actually the regimen that they came up with. So based on this, based on their dosing simulation, they found that the maximum duration of coverage during the case of a surgery the maximum duration of coverage with a safe gentamicin dosing regimen is 11 hours. So when we look at the results, the pharmacokinetic results that were suggested by these two different studies, they actually gave fairly similar answers. The first study, they actually found like a they actually identified a target concentration of 1.6, but the second study, they just went directly with using a UCAS clinical breakpoint of 2 milligram per liter. And then so they came up with fairly similar results. So that's why, as a summary of the dosing guideline, with this updated version of TG, our recommendation is pretty much in line with what's recommended with the latest PK study. So essentially 4 milligram or shorter, you can get away with just 3 milligram per kilo, up to 280 milligrams. And then, so you kind of have to anticipate how long your surgery is going to be. So therefore, you can pick a suitable regimen. So if you anticipate that your surgery is going to be longer than 11 hours, then this is your favorite answer, seek expert advice, and which I will probably tell you just use something else. Yeah. Anyway, so yeah, there's the renal patients recommendations there. And yeah, and so these recommendations, they are based on evidence that have been obtained in the adult population. So there is an absence of data on the pediatric population. So a separate set of recommendations is provided by the pediatric subgroup, and which is still maintaining the dosing of 5 milligram per kilo, which makes sense to me, I guess, because in pediatrics, like we're talking about different body compositions and an increased rate of renal clearance of a hydrophilic drug. I think this is all for me. Yeah. Thank you.
Thanks, Danny. Really great presentation. Does anyone have any questions for our last two presenters? Just Danny.
It's a bit of a controversial one, but thanks, Jen, for your presentation. With the MRSA rates, you've gone with a regional kind of high risk. With MRSA rates falling across the country in most of those locations, they're not low, but they're lower than they peaked at, per se. And a lot of the rest of, say, Western Australia having 25% and above. What's your threshold? The tricky question that no one really knows the answer to, but I'm curious as to what the discussions were.
Come up here because my voice is not very loud. Yeah, we had that exact discussion, and I don't think we have a magic number, but we sort of thought around 20% was kind of our feeling. More than 20% is probably still high, but I don't think there's not a black and white printed number at the moment. Obviously, it's going to be a situation that needs ongoing monitoring as well. Yeah, yeah. I think that's sort of our unprinted, unofficial number at the moment.
It really is worthy of our attention, I think, to think about that number, because we were in the situation where we kept seeing MRSA rates climb to get up to 55%-ish in Alice Springs, but now it's sitting now at 45%. How much more is it going to drop? What's our threshold going to be for changing those recommendations back? And I think we didn't decide on the way up. Should we decide on the way down? I think is the important question.
Yeah, yeah, for sure. And I don't think we have a very good answer yet.
We'll do one more question.
I just have a question about pre-op prophylaxis for unscheduled caesarean sections. My ONG team in my hospital said that the most recent ERAS guidelines recommends addition of azithromycin in addition to cefazolin for unscheduled caesarean sections and in obese patients. I wonder whether TG has harmonized with that.
I'm not entirely.
I'll have to check back on that and get back to you. I can't quite recall, but I'll talk to you after and let you know.